4 years, male castrated cat, long time in the litter but no production, anorexia, and it came to you with a history that is not able to pee, and you feel a very, very large urinary bladder. And this is Silvestrino. My colleague is trying to compress, and you see there is very little coming out. So this is what we do in our clinic. My colleague is Dr. Galluzzi. You might have read some paper that he wrote. He is considered very expert in urethra and urinary problem. He is inserting a catheter just in the tip, and he's giving, the cat is awake, just anti-pain, and he's inserting, just keeping there, atracurium diluted with saline, and then with very little effort, usually the block is gone away, and then it can be. So was easy, we resolved, and we finished, because it was blocked, and now it's not blocked anymore. Why we usually do an ultrasound? For several reasons. One is to check what is still left in the urinary bladder, because if there is a lot of sediment, but another thing is to check this. Look at the tissue surrounding this urinary bladder. What do we see? We are just caudal to the urinary bladder. There is scattering, and most of the time a little of effusion. That is a very, very common finding. What is the meaning? Do you have cats that get urethral plaque? Okay. How do you treat them? You need to remove, and then you put a catheter in all of them?
Yes. Yeah.
Sometimes you just leave it, but how do you decide what to do? Sometimes no money, and then catheter is not an option, but the risk, the very high risk is he came back, is not able to pee. So basically, there is a very nice paper that describes that when you are blocked for quite a long time, again, the urinary bladder might explode and the lymphatic take over and create some effusion, peri-urinary effusion, and this is a sign that the urinary bladder has been too long occluded. So these are the ones that most likely will need a catheter. So we need that to see what to do next. And of course, all the rest. How long the history has been going on, and how hard it was to resolve. This is a transfer. I'm just caudal to the neck of the urinary bladder. But most of the time, especially to the caudal part, you will see all this altered tissue. This is the result of a prolonged occlusion. It's not a peritonitis, but it's telling you that most likely you have atony. So either you put a catheter, or you can, the cat came back twice because you need to be sure to empty properly this urinary bladder. But this could be another interesting use of the ultrasound. Okay. Puffetta. Do you have wolf? The blue little men that live in mushroom? Yes, smart. You have smart? Well, Puffetta is the Italian name of the female smart. We call it Puffy. Is 11 years. She is not eating. She's losing weight for 3 months. And she seemed weak for the owner. A little bit of very high liver enzyme, and we know that it's not very common for cats to have high liver enzyme. So what should we do? I think an ultrasound to check this liver is a good idea. Liver. What do you think of the liver? Hyperechoic, no distal acoustic, no, probably just, might be a little bit. It's not eating a lot, so probably lipidosis is coming, okay? Not dramatic, but just more than what I would be. And then it keeps coming. I feel like, wow, you are me. When the radiologist is excited, it's a very bad news. Very bad news for the patient. Something is coming. Let's have a better look. Okay. Then grab the spleen, the kidney, urinary bladder, the other kidney on the other side, other small intestine. Okay. So, probably that is the most interesting.
Yes.
How many lesions do we have?
1, 2,
Many. When there are too many, it's becoming a little complex. Okay? Which organ are involved? Kidney? No, I don't think so.
liver, spleen.
Well, I'm in the abdomen, and of course, I've checked the kidney. I found 2 normal kidney. This is how I can tell you. Intestine, how many lesions are in the intestine? So 1, we do agree there is a lesion here, okay?
Merong fusion.
This, if you check carefully, there is gas inside. So there are 2 lesions in the intestine. 1 is asymmetric. Asymmetric means that part of the wall is more affected than the rest. See how it's like it's growing outside? But there is a second, symmetric. 2 lesions in the intestine is a big problem, because literature say that most of the time 2 lesions is inflammatory. But do you think this cat has an inflammatory disease? No way, because The first really big mass, what do you think is the origin of this lesion? Let's go. It was the liver. The stomach is here. Scrotal to the stomach is so large that it is basically taking half of the abdomen. But look carefully. The big vessel is close to the colon. It's not the spleen. We have checked the spleen is okay. Is a huge mass lymph node. This is very, very likely a lymph node. How you can say? You cannot, because they became so huge. But what you do? Liver, no. Spleen, no. Kidney, no. Urinary bladder, no. What is left? You check the vessel. Why? Because lymph nodes are along the porta. And you see that the porta is severely deviated and is the only left. So you have two options. Is a lymph node or is a free peritoneal mass. They do exist, but are quite rare, especially in cats. But you cannot do more with ultrasound. If this lymph node will be either the right colic lymph node, we're called to the colon, or the jejunal lymph node. They both drain the gastrointestinal tract. So the only things that don't fit perfectly with an intestinal tumor is that there are two lesions. Does the cat always read the book? The cat loves not to read the book. So this was the spleen, and we were able to follow all the spleen, the kidney, urinary bladder. We will take a sample because it's very interesting. So what are the key points? This is my probably most interesting. So 1 and 2, second lesion, 2 lesions of the intestinal wall, and there's this huge. What we found, because we sampled, considering there was very, very close to the ileochicocolic junction, this is a very right colic lymphadenopathy, one symmetric small intestinal mass non-occluding, one asymmetric small intestinal mass partially occluding, and chronic kidney blah blah disease. How do we interpret? So there is a very old paper, but it still is the gold standard, was written by Dominic Penny, 2003. We still follow her rules because nothing better has been written that tell us that when you have the lymph node thickening, whatever, these are the way to differentiate enteritis and neoplasia. It was 22 years ago, but 61 dog and 81 dog for the time was really, really a lot. Usually were 3 Ks, 4 Ks. And basically, wall thickness a lot for tumor, wall layering normal and lost in 99% of case, and lesion diffuse in 2%. So in 2% of tumor, we have more than 1 lesion. But what we have to do, we have to sample, because it's the only way that we really can make a conclusion, even if literature might not agree with us. So we have a large lymph node, and we are going to take sample of the lymph node and of the mass. So we do our cytology. Lymph node, mass, whatever. We try also the cavity lesion. and we got large granular lymphocyte lymphoma. So it's just behaving a little bit different, but what we do when we found adenomyosis, we go and check, which is the last paper that described this disease. This is a nice paper from 2017, and is in common, is not responding to chemotherapy, so it's not really sounding good. And in this paper they have 109 cards, it's a lot, and usually is associated with the gastrointestinal tract. Median survival is 5 days, few more than 6 months. Very common to have a second lesion, but in this case we have. So what is the key point? Usually loss of layering is most of the time associated with neoplasia, but be careful, especially in cats. We have this eosinophilic fibroplasia, fibrodysplasia, that can mimic a tumor, but it's not. So always sample. Nothing is pathognomonic, but we are lucky because we can ask the clinician, or maybe we are the clinician and the ultrasonographer, and we need to remember that ultrasound is very cool and important, but it's only a little pieces of what is our patient. And always remember, the most important, super cool diagnostic tool is the physical examination. Thank you so much. Any question?
Any questions from the group? This is your last and final chance to your final destination. No.
Hopefully not. And thank you so much for the brave that create this piece of